Welcome, everyone. It's our second hour of our symposium on intimate partner violence prevention, primary prevention, using communication tool in the prevention. I'm going to introduce our next speakers. We have a great duo coming together, Micah Baker and Raina Berrigan. Raina has earned her master's in social work and with an emphasis on public health. Shortly after graduating, she worked for a counseling agency addressing intimate partner violence and substance abuse. Raina has been passionate about working with women and empowering them to participate in healthy relationships and live healthy lifestyles while overcoming past traumas. As a licensed clinical social worker at the University of Utah, Raina has been working in the Women's and Children's Unit for close to 8 years. She is known for working with women before, during, and after the delivery of a baby. She worked with children during and after the delivery of a baby. Raina's work includes providing support, counseling for intimate partner violence, fetal drug exposure cases, and addressing postpartum mental health issues. So we're really happy to have you here. I'm going to go ahead and introduce your partner in crime, Micah Baker. Micah she's a nursing professional development lead specialist for the University of Utah Health. She works in clinical staff education and is our go-to for any of us who are going to do more training and get up to speed on education that we need as nurses. She trains clinical staff and sits on the domestic violence committee and tries to keep up with all the many changes in healthcare. Her background is in critical care, where she has taught professional staff for several years. Her current specialty is professional development, including conference and poster presentations and textbook and article publication. Welcome to the both of you.
Well, thanks for having me. I'm really excited when it comes to talking about prevention. I do a lot of postpartum prevention education, and so this was really kind of exciting to come and talk a little bit about IPV prevention techniques and things that we can do for that. I wanted to start off with talking a little bit about therapeutic techniques that we can use when meeting with patients and clients. I sent out a PowerPoint, but one of the things that we wanted to touch upon was building rapport with patients. I know a lot of times when you're meeting with somebody and trying to get to know them and they're coming in to do like a pap smear or something like that, it's not always the most comfortable setting for a patient. So sometimes being able to normalize and validate that and let patients know that we can kind of understand where they might be coming from can really go a long way with building rapport. A lot of times our patients, they have to take time off work to come to a medical appointment. And so being able to just validate that and let them know, sometimes it can be stressful to address your medical health or needs, and we're here to help support that. And that can give patients kind of a sense of security and approval that it's okay. We know that you might be feeling these things and we want to be here to support you. As a medical staff member, being relatable, letting them know if there's something that I can do to help understand whatever information we're talking about, let me know. I'm happy to help so that you're comfortable with the treatment that we're giving you. Avoid forcing our agendas. A lot of times we have maybe like questionnaires and screens that we want to do, and we don't know a lot of maybe the trauma or the past experiences that our patients may have gone through, and so we just want to make sure that they're able to that we recognize that they're going through that, and that we want them to be comfortable. And so if they are not ready to answer some of those questions or ready to talk about the questions or the feelings that they may be experiencing, or if they're in an unsafe situation, that we're not going to force them to do that. The patient is the experts of their situation. So just recognizing that we don't know what circumstances our patients are in. And so we want to be respectful of that and help them navigate through that experience with them. I wanted also to share some risk factors for people who might be at high risk for IPV. I think that the next slide shows IPV risk factors, and it just kind of talks about so if one of our patients has a history of abuse, disabilities, being a young age patient, we see a lot of 14, 15, 16-year-olds, low academic achievement, low self-esteem, untreated mental health conditions like depression and anxiety can be some risk factors for somebody. Belief in strict gender roles, lack of bonding with children, employment loss, and isolation. And so when our patients are coming in, and if we're seeing some of these risk factors, that can be a flag for us to know that they might need some of those resources for IPV prevention. And the two that I'm going to focus on are the lack of bonding with children and the employment loss, just because a lot of our IPV assessments typically have these two on there. So those are two that we commonly see on the Sahara or the danger assessment. The lack of bonding is mainly because the only studies that we have are male-female relationships. And they show that when a mother is dating a new person that is not the father of her children, that she is likely to be at more risk for intimate partner violence. So that's kind of one of those red flags. So if we know that one of our patients can be in that situation, or that they're going to be at higher risk, making sure we offer those resources and check in with them and just letting them know that we are available to help if any concerns or questions come up for them. The other one is employment loss. Part of the work, the other work I do groups for intimate partner violence, people who have been charged with domestic violence. And then I do some work with individual therapy for victims of intimate partner violence. So I recently was working with the client who was charged with intimate partner violence, and he was recommended by the court to attend 24 group sessions. And as we got into talking about his situation, he reported that when COVID had started, he lost his job of 20 plus years. And so he'd been working there for a long time. And there had been some intimate partner violence going on in the home already. And I think this was a catalyst for him kind of going to that next step of making IPV even worse in the home. And so processing that through with him, I wondered if we maybe would have offered some resources and helping with like knowing if he had lost his job, how to best support him. And one of the concerns that was brought up with him, he said he had suicidal thoughts at the time. He was feeling like he wasn't able to provide for his family. He had lost his identity. And so essentially what happened is he started to take all that anger out on his partner and family. And then he was court ordered to attend treatment. And so those are probably the two that I have seen on our Sahara and danger assessments when talking about intimate partner violence. And so that's why I wanted to highlight those two risk factors. So whenever we're meeting with patients and we see these, we definitely want to offer those supports and resources, even though they might not be experiencing intimate partner violence or we don't know about them. The next slide talks about the equality wheel. This is one resource for prevention. Oh, perfect, great. So this is something that I use a lot with our patients and with clients. I think it's a very easy way to kind of look at what a healthy relationship should look like. And if it's possible to have these like in our clinics or, patient rooms or things like that, this might be something that could be pretty helpful for people who are in, oh, perfect, that's great. That's the slide right there, thank you. To help people who are in IPV situations, not only just see the power and control dynamic in the home, but see what a healthy relationship should look like. And a lot of times it could be a conversation starter if patients see these handouts, in the waiting room, or if they're posted on the wall, they go into their appointment or into the hospital, and they can maybe start a conversation with their care provider about what this is and how we can help achieve this in a relationship. I kind of got this idea from a 5-year-old. I was talking to one of my friends that works at the WIC office, and she was telling me a story about a young woman who came in with 3 kiddos. She had a 5-year-old, a 2-year-old, and a baby. And she seemed pretty stressed out, and she seemed pretty tired, like she hadn't slept very well. And she decided to give the kids crackers to kind of help her manage the 3 kids while she was waiting for her appointment. And it turns out that the kids made a mess in the office. So there's cracker crumbs all over the place. And she kind of just stood up and got frustrated and said, "You guys made a mess." And her 5-year-old turns to her and she says, "Mom, maybe that's why the sign says no food in the lobby." and just kind of made this remark. And so a lot of times, even kids at a young age are paying attention to this information. And so if we have opportunities where we can educate in different ways, whether it's families waiting in a lobby area or if it's inside a patient room, so that people can see that there's other options of what a healthy relationship should look like. So I love working with the equality wheel. This is something that I hand out often with patients. So right now, one of the other steps we're taking for IPV prevention is we started a project with Bernice Tenure and Jeff Coombs from customer service. We are working on trying to help partners be more involved in the process of prenatal care, labor, and postnatal care. And the reason for that is we have some scholarly articles that have been written about parents who are involved in the care of our child are less likely to be violent in the home. And so this is a way that we can focus our attention on how to help reduce the chances for IPV with families. So one of the things that we do now in labor and delivery is parents are involved to help during the labor process. When the baby is born and mom is tired and doesn't have the energy to hold baby, the partner can do skin to skin with baby. That will promote some of that bonding. We have partners that now help with breastfeeding and with pumping. And so they are becoming more and more involved in this process and being able to see that their part and their role is important in this, and that they can be somebody that can help support and foster a safe and healthy environment for the family. Another great resource that I use is the 211 resource list. We can change that slide too, if that's okay. Thank you, appreciate that. So the 211 resource list has a list of different things that are available for families. So this is really helpful because it has a section on intimate partner violence. It has a section about places where you can get help for employment. It has financial counseling, resources where families can get help, assistance for WIC. And the reason I like this is it doesn't single out any specific resource. It's something that's in general. And so families can hang this up on their refrigerator. And if they have any of these needs, they can kind of refer to this for that help and assistance. And they have a number they can contact. And sometimes it's less intimidating to call somebody or do something on the computer than having to see someone face to face. So that's another thing that we can do to help support families.
I'm wondering, can we get a copy of that and share it with the participants of that form?
Yeah, absolutely. I will scan it and email it to you if that works.
Okay, that would be great.
Perfect, yeah. Another thing that I included in here is a lot of the John Gottman resources I use with a lot of our patients, especially after, for me, having a baby. It's really stressful when people don't have a lot of sleep and they're trying to figure out how to parent a new child. And so it can get a little high stress for families. So I pull out a lot of his information on communication techniques, on ways to work with your significant other as a partnership. And this is another thing that we can also use with patients. It's easy to Google. A lot of times I will pull it up on YouTube so patients can just go on there and see some of the techniques that John Gottman recommends. And a lot of patients have liked that as well. And another one, this is a humanizing and holding the person accountable. So kind of going back to the client that I talked about first, after losing his job of 20 years, he took out his stress and anger on the family. And there's space to recognize that was a tough situation for him. He lost his identity, didn't know what to do, was becoming suicidal, but also saying, you need help and knowing how to process these feelings, and you need the skills to be able to provide support and a safe and loving environment for your family. And so that's why we are going to help you with therapy. And so being able to balance those two things, I think, are really important when dealing with IPV. And then emphasizing that our patients can come to help for help with us. I think a lot of times when we meet with patients and we want to talk to them about these sensitive subjects, and we don't always maybe get across the way that we want to with our patients, just letting them know, hey, I'm here to help. I don't have all the answers, but I can find somebody that does, and just know that you can come to me if you need any support or resources. And I learned this early on in my career when I first started working at the U. I had a family that I was working with. I usually get a list of patients that I have to see in the day. And when I came in that day, I had a list of like 3 or 4 different consults for that same patient. So it turns out that the partner was very irritable and aggressive, and there was a lot of concerns for IPV with this family. So I attempted to go in and talk with the patient, and the partner threw me out of the room. And so I said, well, this is not going to work. I have to go and talk to security. So security came up and they helped me. In the process, they asked Dad to step out, and then I was able to just meet with the patient. And I could just see that she was stressed and frustrated. And I just said, I just wanted to meet with you and just give you these resources. So I gave her the 211 resource list, and I let her know there's just information on here about intimate partner violence, about assistance for jobs or counseling, if anything like that. If you need anything like that, just know that this is available to you. And then I wrote my name and number on the bottom of the sheet, and I stuck it in her folder so that she could take that home with her. And then I walked out of the room thinking, oh my goodness, I just caused this big ruckus for this family, made them feel uncomfortable, and I don't even know if they really needed the resources. So a year later, I get a phone call from this patient saying, I'm ready to leave this situation. I'm really scared. My partner has guns in the home, and I have 2 kids, and I don't know how to leave out of this safely. And I just remember you left your phone number and your name, and you said you could help me. And I was surprised to get that phone call. And sometimes we don't always know how to respond to these situations. So I just talked to her and said, would it be okay if I call the police, have them come and grab you and the kids and take you to a shelter? Are you comfortable with the plan? And she agreed that she was comfortable with that plan. And so I called the Wendover police and asked them to go pick up this family. And so they did, and they were able to transport them to a domestic violence shelter. But if you would have asked me when I left that room if I would ever hear back from that patient, I probably would have said never, And so leaving that door open for our patients and clients to let them know that they can always come for help and talk to us. And this client that I work with, who was referred for domestic violence, he graduated from his program. And I said, just know you are always welcome to come back and receive support and resources. It's better to come and get the tools that you need to prevent an incident like this from coming. And as we process that, he agreed with that. And so he knows that his prevention plan is to come back to counseling and therapy if he ever gets to that point again. So leaving that door open to give help and resources for families in the process of also humanizing and holding them accountable, I think is an important part of ways that we can prevent intimate partner violence. And our goal at the end of the day as healthcare providers is to have our families feel safe and healthy and be able to help in whatever way we can to support them. And so I'm excited to have these conversations and to be able to participate in this process of reducing intimate partner violence and educating and having the hope that as we continue these conversations, our generations will continue to change and we are going to move closer and closer to having safe and healthy families. And so that's the information that I wanted to share with you today.
That was great information. And I like the perspective of what can we do when we're actually working with our patients. And that was a very moving story, because I think that represents what we can do as individuals when you offer help and support. Thank you very much for that. That was great.
Yeah, thank you. Thanks for having me.
Thank you for that, Raina. That was awesome. I love hearing you tell that story. I was trying to watch the poll to see, it looked like we have mostly nurses with us, but also some social workers. Were there any other roles?
We have a few EMS providers.
EMS, great. My background is all very working with clinical staff. I loved that we led off with bystander. I think as clinicians, we all feel like, we have to be the hero all the time, and we can't just be that bystander. We have to jump in. But I I thought everything that she shared was really helpful for us to keep in mind too, as we're trying to build relationships with our patients. So this is just a short snippet of what we teach staff in our orientation for our clinical staff here at the U. I think one thing that really helps us as clinicians is to really understand our reporting laws. And I will tell you, I'm always amazed at how confusing this is. It's really hard to know, what do I legally need to report? What do I don't need to report? There's always a lot of confusion. So I just want to make sure everyone is well aware of that. And it varies by state. If you're not in Utah, I'll speak to mostly the Utah laws. You can see from our Utah laws that you've really got to know your state law well when you're talking to patients about this. Our main objectives when we're teaching clinical staff is that we're making sure they understand some of the trauma-informed principles when we're talking to patients about these topics. What does that mean to have a trauma-informed approach? Our next one is employing best practices. So I'll start off with how do we talk about that trauma-informed approach. Trauma-informed care, make sure our main goal is to not re-traumatize the patient when we're talking to them. We realize the impact of trauma, we recognize the signs and symptoms, we respond, we make sure that we think about trauma when we're writing policies and procedures, and we avoid that re-traumatization when we're bringing this up with patients. So that is just the background of trauma-informed care and making sure that we're approaching every conversation that way, right? Turning this perspective, really making sure, right? What happened to you is not nearly as important as what it means to you. And this is just a great quote about it. Trauma-informed care embraces a perspective that highlights adaptation over symptoms and resilience over pathology. That's our main goal when talking to patients. Next objective is to employ best practices when evaluating patients when talking to them about these topics. We actually have a 95-page reference manual. This is how complicated this issue is for us as clinicians. And there's no way, it's really difficult for clinical staff to memorize that manual, right? So we kind of have to really hit some basics pretty hard, especially when they're just coming through orientation and kind of hearing about our policy. So we make sure first they understand their reporting requirements, and then that trauma-informed care basis, and then what are their resources when they're in these situations. So our policy is just called abuse, neglect, and exploitation, and it encompasses any situation in that. So it's got a huge scope. Sometimes I think it's a little too big, but it is a very a large scope. So we just quickly introduce the topic, and then there are kind of 5 main algorithms, and we show staff how to navigate those algorithms, because that's where most of their resources are. So how to find the resource, how to navigate the algorithms. And I'll show you those in a second. It's a tricky thing, right? To make sure you know this, what are my state laws? And this is about what I see. Some people, oh yeah, I have no, they just moved to Utah. I get people who have just moved to Utah. Oh, I have no idea what the reporting requirements are, or what, you mean it's not a lot of people don't even realize it's state by state. Utah Health Code, injury reporting by healthcare providers. I mean, you can read this. It's fairly jargony. It's really hard to understand. So we first of all, we have to make it a little more manageable for staff. We break it into populations, because this is kind of the easiest way to think about it. For us, 0 to 17 years, all adult citizens are mandated reporters. If patients disclose anything about neglect or violence or exposure, even exposure to violence, right? Our Utah state law says we are mandated reporters. So our algorithm around child abuse and neglect gives them those law enforcement resources and DCFS resources that they need, and then tips on how to have these conversations with caregivers. So that's that population. And then our vulnerable adults are the next, like right? These are kind of easy populations to define, although sometimes people struggle a little bit with who exactly are vulnerable adults. So we kind of talk about, vulnerable adults being those people who really rely on someone else for any basic ADL. They need help with eating, shopping, any kind of clothing, any help managing their money, help with anything like that, right? That would put them in that vulnerable adult category. And so same thing, right? It's an immediate, if you have suspicion or anything is disclosed, that's an immediate law enforcement or adult protective services reporting. So then a population we are talking about are, there's not a great definition for them. So on our domestic violence committee, we call them non-vulnerable adults, which is kind of not the best term, but it's sort of an easier way to think about it, because there not as many mandated reporting with them. So our non-vulnerable adults, if that's helpful to think of them that way, right? So they're 18 plus and they're independent. They don't rely on anyone for anything. So we healthcare providers are mandated to report in Utah when we are treating an assaultive injury, or if we know that children are exposed to violence, if that is disclosed to us, and we are mandated to report that to law enforcement. So that can be hard for some people to hear. I know this is different, for example, just in Wyoming, and we have a lot of people who come and work here from Wyoming, and they're not used to that. But that it's that assaultive injury. If we're providing care for the assaultive injury now, that's our reporting requirement. So let's just show you a little bit of what the algorithms look like. They are hard to navigate, right? This is very difficult when you're trying to have this conversation with a patient. So we try to give some resources. The other great thing in our algorithms is that when you click in, anything that's gray and underlined takes you to a great resource. So if you're not finding what you need within the algorithm, you can click and find more information. So that 211 sheet that Raina talked about, that is this resources page. So if you look in, I don't know if you can see my arrow here. So if they screen negative for intimate partner violence, and you are not treating an assaultive injury, right? Some verbiage you can use, and then if you click on this resources, there's that 211 sheet you can print. Although I will say that not a lot of people know what 211 means anymore. I think that's a generational thing, right? So it's sort of an information sheet with all those resources, a resource sheet. So here in the middle is kind of, right, the goal is to get them to their, if they need to report, what are the phone numbers for them? And we have an amazing lead of our domestic violence committee. She's a fabulous pediatrician here that I know has been involved with this group before. Dr. Franchek, she put together these algorithms with all these great resources and even made them interchangeable, right? We have health systems all over in many counties. So she went to the pains of figuring out the phone numbers, the reporting phone numbers in all the counties in Utah, and put them in here based on location. So staff can look up and find the phone numbers for their locations. And our risk management department here is a great resource for us as well. And I would hope in other, if you guys work in other healthcare settings, that you have a risk management team that can help with this as well. It's always a hard conversation and decision to make. And hopefully you don't ever have to make it alone. We also have a sexual violence algorithm. So this, another thing that can be a little bit tricky to navigate. So we have this algorithm to help staff with that. Some resources, right? Lots of resources here. We always want to make sure we're taking care of that patient first, and then helping them with the resources they need. So there's that resource list right down here again as well. A little bit tricky. This is that, if they're 17 and younger, they do fit into that reporting category. And if they're 18 and older, right, they're not necessarily in that automatic reporting group. We have to think about that when we're going through this. Another one of the pieces of our algorithms in our policy that we go through is human trafficking. This is another great resource for staff. This can be really hard to see sometimes for us. This is really helpful. These algorithms are all pretty, sometimes you think you're in an intimate partner violence situation and it can easily, and then you realize, well, it's really human trafficking. So you can easily navigate around this. So I think having these resources for us as staff, as clinicians, helps us figure out, right, what do I have to report? And then how do I make sure my patient knows what I have to report?
Question for
Yes.
you. These algorithms are great. I think that, it may very well be that other facilities don't have something already developed like this. So hats off, this is really good. My question is, who do you teach this to? Is it just like incoming new grads or new nurses, new hires, or do you have, is there an opportunity to offer this regularly and as part of their annual education?
Yeah. We would love to do both. We teach it as part of clinical orientation now. So everyone who comes to clinical orientation, which is every clinical role, I mean, we get everyone in there from nurses to psych techs to, we get EMTs, we get a lot of different roles. We don't get everyone. So our committee tries to do other work. Dr. Franchek is constantly working with the residents on this because it does take, it's one of those adult learning principles that sometimes it's great to know, okay, great, we have this a great abuse, neglect, and exploitation policy. And then, I work in an area where I don't ever see that. But so then the one time I am confronted by it, I forget, right? And now I'm like, okay, what was that resource? And now I'm ready for this information, because this is not an everyday for all of us. So it's hard. I would love to have an annual thing. Right now we don't, but that is a goal. That's one of the things we're working on right now.
Yeah, good. Well, I just think of our year-long, this whole education process that we've been going through, and one of them is looking at your, what are the cultural norms within your facility? And what we had noticed when we did our needs assessment was that people were getting regular training every year annually on sexual harassment, but very few people were getting training on these types of things. And so I love seeing that this is actually already done, and
yeah,
I look forward to seeing how we can implement that potentially.
Yeah, we created annual education, I don't know, 3 years ago, and never got to publish it because things changed. Guess what? Yeah. It's hard keeping up with everything back on the table. It's in the works. It's a tough one, especially so for my department creates education for everyone. So you can imagine training for a medicine resident is going to look very different from training for a psych tech at uni versus, right, just the different roles that we reach out to. So it's really hard to make it meaningful for everyone. And really our main goal is to make sure they remember those mandatory reporting requirements, and then also give them tools to have these conversations if they need to
Yeah.
when it's not a mandatory reporting situation. And also I
was gonna say, Jamie just wrote in here that the next, our next EMS grand rounds focuses on human trafficking in the trauma patient. And some of you at your own facilities may find that this is a starting point of getting the conversation going within your community and your staff, and then reaching out to how can this be a norm? You know, the discussion about intimate partner violence, domestic violence, violence in general, and human trafficking. So
I think actually it was perfect because I think, was I going to do my next poll here? I think sometimes we find ourselves in this conversation pretty deeply before we realize, oh, maybe my patient doesn't know that that there are things I have to report. Starting off that conversation and making sure they know if this is an assaultive injury, that's something I've got to report. And then making sure they understand they don't have to talk to police, but that's part of my role and my position as a clinician is to report that. So that's great.
yeah, and some of the previous discussions that we've had throughout the year have included kind of what that means in reporting and how to, you know, put some empathy within that.
Yeah, it can be as simple as just starting off like, you know, describing, right, there are some mandatory things that I'm required by the state of Utah to report. I just want to make sure you know what those are. But yeah, that's very important to build on that trustful relationship for sure. A few resources. So Raina talked about the resource, the 211 list. It has many other resources, right? Really important not to give them anything that could risk further harm. One of the reasons we didn't launch our annual education was because we were working on these dot phrases. Part of the hard part for us is, as clinicians in the moment, it's really hard to say, you know, hold that thought, let me pull up my abuse, neglect, and exploitation policy and see, you know, follow my algorithm and make sure I'm saying the right things to you. Really hard to do that. I hear all the time from patients who say, right, why does my provider stare at a screen the whole time they're with me? You know, that can be really difficult, and these conversations are hard enough to have without us being on the screen and not talking and looking at the patients. We wanted to make those algorithms even more accessible than they are. Right now they're within the policy, a little buried like you saw, so not super accessible to all our clinical staff. One thing that they can do is use a dot phrase. If they pull up dot abuse, domestic violence, it gives them the same phrasing and resources filled into a note in their electronic health record. So they start a note, create a note, and put in dot abuse, domestic violence, and it's like a template that comes in with all those resources and reporting requirements and phone numbers, and they just delete what they don't need, right? Because it's not going to be the same in every situation. But those have been really good, and we've been working on those for so long. So now that those are ready, we can work on that, getting that annual education out there. A new twist to all of this that we just learned about is the Cures Act. I don't know if other health systems have adopted this yet. We're kind of adopting it in phases. Our provider notes have been visible to our patients for a long time, several years. I think they go pretty quickly into their, you know, we use the Epic documentation system for our electronic health record. And our patients have a program called My Chart where they can go in and make appointments and see things about their visit, and they can see their provider notes. And the Cures Act, we're going to adopt a portion that makes more of their chart available to them on April 5th. So nurses notes, social work notes, any other kind of note, not just our provider progress note. This is a new thing for staff. I know a lot of staff are having a little bit of a difficult time with it. One of the hardest pieces is we need to make sure that our patients aren't going to be at risk for further harm based on our documentation. So One thing we can talk to them about is if they have a proxy for their chart, can someone else get that information? And especially with my chart, it's how immediate it is. So most of the time, a family member can, or a spouse can go and request a paper chart from our records, but we've always been able to block certain things. So any notes around, that's one thing our domestic violence committee did, was work on blocking anything, any kind of diagnoses or documentation around domestic violence that we thought could put that patient at risk for further harm. We were able to kind of hide that from the chart, so someone going looking for it couldn't find it. And that's a little bit harder now with the Cures Act. It's still doable. Staff just have to make the conscious decision there's a button they can push before they publish their note to withhold it from the patient. But it's pretty, right, we've got to be really careful with that. So we've got to know that the patient is at risk for further harm when we do that. So that will be a new thing for our staff to deal with. The last thing, so that those are some of the best practices as a domestic violence committee we've been able to use in our institution in teaching staff. But yeah, we do hope this will happen more regularly. Members of our domestic violence committee do go and talk to specific groups. So I know a lot of departments who deal with this on a more regular basis invite people to come and talk at staff meetings and make sure staff's questions are answered so they know what they need to do in these situations. So I know we're getting out there. It's just not as, I think some of the stuff needs to be very regular. Like you said, Linda, it needs to be normalized. It needs to be more like clockwork and happening easily versus no one should have to go out of their way to find this information. So part of that culture. So one thing we're hoping to do is make sure our patients feel safe in talking to us and we're able to have these conversations with them. It was a really hard weekend for this. So
yeah,
there's a great group called Polaris. I'm sure you guys have talked about them. And Catherine Chen, the CEO, does a lot of great work around intimate partner violence and human trafficking and a lot of prevention. This is also a great source, but this was a good story that she put out and she wrote for USA Today.
Thank you, Micah. That's a tough one to share for sure. And it has been this weekend and last week have been a very prime examples. So thank you for sharing. And
yeah, thank
hopefully
you.
This will promote us all to be again involved and aware of our surroundings and, maybe move up the whole question of violence to a higher level. Thank you for your time and for your vulnerability and your expertise. It was really, really helpful. We do have Raina, so thank you, Micah, and we appreciate your sharing.
Thank you, Raina.
Your expertise. So
what do you recommend is there something that you may have covered this, Micah, but what do you recommend if you're concerned that the abuser might be in the room in terms of asking the question?
Yeah, you've got to get that patient alone. I mean, Raina probably deals with this way more than me, but what I talk to staff about is distraction, like one of the other things that, can I distract that family member? Can it be suddenly time for an x-ray? Can it be suddenly time for something that I need to get the patient alone for?
I walking to the bathroom with them saying, we need a urine sample, and in the emergency room, I'll walk to the bathroom with them, or I've even gotten people to talk to me on the way to radiology. That's something.
Yeah,
You've got to get them alone. I think even too, to ask them if someone has a proxy to their chart, that can be a triggering question, right? So I've got to get them alone, even to ask that question. Any of these questions, I think that we've got to talk to them alone so they feel safe.
If so, in the triage portion of the charting that we do, if we click unable to assess, do you know what happens? Does it get like recircled back to?
I don't think it does.
Okay.
Unless someone goes back.